Okay, so my plan to record it on Thursday didn't work, so I'm recording it on Friday instead. I've had some pretty bad headaches recently, so hopefully it's still good. So first of all, what I did is I looked at the blueprint, and this is the blueprint. The way I do is I divide it into colors. Most of the questions are going to be coming from chapter 48. We have 8 med questions. It looks like most of them are coming from the diabetes chapter. And then the 2 med questions that come from chapter 49, one of them looks like it has to do with the parathyroid gland, and the other one looks like it has to do with the adrenal gland. So I'm not quite sure what those medications might be on. And then for her lecture in the diabetes chapter, she mentioned that mostly the insulins that you would be seeing would be rapid acting and then long acting. So I'm thinking that she probably isn't going to have a whole lot of medications on intermediate or short acting, but I would still kind of like go through them a little bit, just a little bit, not focusing on it. That's what I'm going to do. I think she's going to focus on rapid acting, long acting, and then the oral anti-diabetic agents. So I'm just going to go through the pharm guide first because I think that's relatively easy to go through. And then I'll do a little bit in chapter 47, 48, and then 49. So let's see what we got here. Okay, so diabetes pharmacology guide. She posted this and she said that the meds that she's going to test us on, they're going to be on her pharm guide. So that's going to be helpful because it's a lot better than just going through the book and not knowing which ones you have to choose from. So with insulin, the onset is when blood sugar will start to come down. So we want to make sure that when they have insulin, they have like a meal right there for them. So for an example, with the rapid acting such as Humalog, the onset's in 15 minutes, but you want to make sure that the meal is eaten within 15 minutes of administration, since that's when it's going to start bringing the blood glucose down. The peak is when the blood sugar will drop to its lowest. With insulin, it's you're going to give it to all type 1 diabetics, and then some type 2 diabetics, depending on how severe their diabetes is. So we have the rapid acting, so we have Lispro, which is Humalog, Aspirate, which is Novolog, and then we have this other one, which I don't pronounce really well, and I haven't really seen. And then those should never, any of these insulins, rapid, short, intermediate, they should never be mixed with the long-acting insulins, such as Lantus, Levemir, and then there's another one that I really can't pronounce. Anyway, I don't see a whole lot of these on clinicals or questions or anything when I'm studying. Mostly I just see Humalog and Lantus, so I think that humans cannot live in Atlantis because it's like an underwater city. So that's something I use, and then like Lantus is similar to Levemir, so then I just kind of associate those two together. And then Humalog has a log at the end of it, and Aspirate has Novolog, so I associate those logs together. So it's humans do not live in Atlantis, like Humalog does not mix with Lantus. So if it helps, I guess it's good. So with the long-acting, they have an onset of 0.8 to 4 hours, but she said in lecture that they don't really have an onset, like, well, they don't have a peak time. They do have an onset time. Never mind. She once said that you can give them in 2 doses. You can just give them in 1 dose. It doesn't really matter. Some people have them in 2, and some people have them in 1. So if that was like a answer on a test question, I don't know if I guess I could go either way. She said that some people tolerate it better when it's given in divided doses. So anyway, I would just be a little careful about like if there's like a question or an option on that, because it could go either way. Okay, so let's go back to rapid acting. So the onset's in 15 minutes. The peak is from 30 minutes to 3 hours, often used with the sliding scale, then long-acting insulin coverage, which is basal. So she said that the way that the pancreas acts is you have this consistent consistent output of insulin, and that's like the basal rate or amount of insulin. And then anytime that you eat a meal, then your insulin spikes. So that's, you would have like a long-acting insulin to give you like kind of like a steady input of glucose into your cells, and then whenever you eat a meal, then people would like program into their insulin pumps or give themselves an injection of rapid acting insulin to replicate the pancreas. Short acting, which is regular, it has an onset of 30 minutes to 1 hour. It peaks in 2 to 5 hours. It can be given IV for acute control. So like if you have someone that comes in with maybe like ketoacidosis, something like that, where they have a really high blood glucose level, I guess you could give it. Intermediate acting, which is the NPH, she also says that's not used often. Onset is 1.5 to 4 hours, peaks in 4 to 12 hours. It can be mixed with rapid short-acting insulin, and the way you would do this is clear to cloudy. Short-acting, which is regular, is clear, and then the intermediate, that's cloudy. The reason that she says you wouldn't want to use the short-acting with intermediate acting is because it causes spikes and drops. You want to keep it more consistent. You keep it consistent with the long acting, and then whenever you have a meal, you have like these little spikes for the rapid acting. So I think we covered that. With the well, we'll go through it a little bit later. Then you have the oral anti-diabetic agents, and the IDE is a common ending. So you have metformin, and that reduces glucose production by the liver, improves glucose transport into cells. It is used in prediabetes. It can cause diarrhea. You can also have like nausea, vomiting, I guess. It causes some GI upset, so just kind of be aware of that. If it's a GI symptom on a test, it, could be a side effect. Hold prior to iodine contrast and for 48 hours until after creatinine is within normal limits. So if they're having like a CT scan, you know that they're going to have like contrast, then you would like make sure that they hold their metformin. And if they've taken it, she went and said that they might try to flush it out with IV fluids first, but they're gonna do kidney tests to make sure that you have adequate kidney function. But ideally, you wanna make sure that they hold it. And what it causes is lactic acidosis, and then that lactic acidosis, it can, with the contrast dye, cause acute kidney injury. So I don't know the exact mechanisms, but that's basically it. And then you have the glitopridol or sulcidide, or this one here. And that increases insulin production from the pancreas. And then you have the pradin, which is the rehadrin. Can't pronounce that one either. So it increases insulin production by the pancreas. You want to take it 30 minutes before each meal. And then you have the acarbose. That slows the GI glucose absorption. You want to take it with meals. And then you have the sitagliptin. That inhibits the hormone, which increases insulin. So it inhibits the hormone, and that causes an increase in insulin release. This one is a little bit special because weight gain is not a side effect of this. So a lot of like medications, she said, get pushed because they have like weight gain is not a side effect of it. So then they try to like also like get people to take control of their diabetes, but also like saying like these medications, they do help, prevent like excessive weight gain and everything. And sometimes, I guess sometimes it might even cause weight loss. I'm not sure. And then we have another one, which is subcutaneous, stimulates the release of insulin. That's this one. Okay. So, One of the common side effects with all these medications, insulin, the oral anti-diabetic agents, is that they have a side effect of causing hypoglycemia. So you're going to want to monitor their blood glucose levels. And there's a med chart in here that I want to just follow up on. So they say that the metformin must be held 1 to 2 days before the IV contrast. And then you want to wait 48 hours and monitor the kidney function test before you give it. The glitazepine, that one it has the side effects of weight gain, hypoglycemia. The repagilin, that one has weight gain and hypoglycemia. The arcarbose, that has gas, abdominal pain, diarrhea. So a lot of these have like the GI symptoms, and then they also have hypoglycemia. So that should be a relatively easy way to remember them. So anyway, metformin is the most effective first-line treatment for type 2 diabetes. The medications for diabetes work by working on the insulin resistance, the decreased insulin production, and the increased hepatic glucose production. So they're gonna affect one or more of these things. So, and then with the metformin, you do not want people to take a lot of alcohol intake, because one of the things that alcohol does with diabetes is it inhibits the gluconeogenesis, like the breakdown of glycogen into glucose by the liver. It can cause severe hypoglycemia in patients on insulin or oral hypoglycemic medications that increase insulin secretion. So you don't want them to be taking alcohol, because it can just cause severe hypoglycemia. Moderate consumption is 1 drink per day for women and 2 drinks per day for men. A patient can reduce the risk for alcohol-induced hypoglycemia by eating carbohydrates when drinking alcohol, because you have the carbohydrates to kind of offset hypoglycemia that can be caused by drinking alcohol. But typically with the nutrition teaching, we don't want people to have a lot of alcohol, so it's something you should be teaching anyway. So it seemed like when I was listening to her lecture, she's going to focus the exam on things like education. She once said that there's 4 types of diabetes. She's not going to focus a lot on the 4 types. The first type is prediabetes. Let's see if I have my notes here. Okay, so we have the prediabetes, and that is... I'll find it in the book a little bit later. We have the type 1 diabetes, and that was juvenile, but now they changed it to just type 1. And that is the progressive destruction of B cells by the body's own T cells. The pancreas cannot produce its own insulin. It can be autoantibodies or idiopathic, meaning they don't know what caused it. It has a 3 P's, so you have polyphagia, which they're very hungry. They have polydipsia, which means they're always thirsty, and then they have polyuria, which means that they're always urinating. The reason that they're always hungry is because they are using fats instead of the glucose, because they don't have insulin to take the glucose into the cells, so they're doing it with fats and other means. They're not using the glucose. The reason that they are always thirsty is because their body is always trying to get rid of the excess glucose. Since they can't take it into the cells, their body is just overwhelmed with glucose and has to flush it out in the urine. This makes it hard on the kidneys. The reason that they, that's the polydipsia and the polyuria. They have to flush it out of their system, and the reason they're hungry is because they're using another means of cellular energy. And then with type 1, they can have diabetic ketoacidosis. I think that we've kind of covered it enough that it should be relatively easy in our mindset. With this, you can have like ketones in your urine. You can have a very high blood glucose level. You can have Kussmaul's respirations, and that's related to the metabolic acidosis. You get metabolic acidosis because you have this breakdown of the body's not using glucose, so then you have a breakdown of all these other like products, like you go into ketosis, so your body's using the fats and stuff instead of the glucose, so you have this breakdown, and then the byproducts of the metabolism, they're acidic, so that's where you get the metabolic acidosis from. And then because it's hard on your kidneys, you can have like a little bit of a kidney problem there, because your body's not really supposed to be filtering like a lot of like large byproducts, I think. So, and then they can be sweaty and stuff. So that's, I mean, we did it in Sim one day, and there should be like a chart in here where it kind of goes over it. It's on page 1142. So that's when they don't have insulin and they can't take it in. So then you have ketones, which are the acidic byproducts of fat metabolism that can cause serious problems when they become excessive in the blood. Ketosis alters the pH balance, causing metabolic acidosis to develop. Ketonuria is a process that occurs when the ketone bodies are excreted in the urine. Electrolytes become depleted as cations eliminated along with the other ketones in an attempt to maintain electrical neutrality. And then they have a comparison of hyperglycemia and hypoglycemia. That's on page 1143. I'd kind of go through that. The clinical manifestations of diabetic ketoacidosis to keep an eye on are dehydration, poor skin turgor, dry mucous membranes, tachycardia, orthostatic hypotension. Early symptoms can be lethargy and weakness. And then they have some lab values I would pay attention to. I would pay attention to the lab values for your glucose. I would pay attention to the lab values for the pH, the sodium bicarb, all those I would know the normals, and then what they would indicate. So with the compensated acidosis or alkalosis, I'm not very good on, but I know that if the pH is, let's see, if the pH is less than 7, I think 35, then it's acidosis. I have a pretty bad headache. But yeah, just know what the acidic is, and then if it's metabolic acidosis, then your bicarb is going to be low. Your bicarb normally is 22 to 26, and if it's acidosis, it's going to be below 22. If it's like respiratory, your bicarb is going to be normal. It's going to be your the other values that are going to be off. So, because if it's metabolic, then your body's not keeping up with its bicarb because it's using up the bicarb. Okay, where was I? So we talked about type 1. So let's go to prediabetes. So prediabetes precedes type 2. They don't have a prediabetes for type 1. So if they have prediabetes, you want to give them a lot of education, nutritional education, exercise education, proper diet, all those things, health promotion education, so that it doesn't go on to develop into type 2. Type 2 seems like it's like a serious problem in our country, so it's definitely a priority to teach them, because you don't want them to develop type 2, because it's just, I mean, if it's preventable, why not? And then there's health conditions and medications, and what I got from our instructor is that even though people are on medications, they can still have a lot of side effects, and medications might not be entirely effective. So, like, if you can prevent something, then it's better than to try to deal with it when you have it. So when you're studying and taking the exam, try to go along the lines of like preventing through education, stuff like that. I think that's going to be a pretty good choice. So the normal blood glucose range is 70 to 110. Let's see here. I should have something about prediabetes. Alright, here we go, prediabetes. So Prediabetes is defined as impaired glucose tolerance, impaired fasting glucose, or both. So, a diagnosis is made if the 2-hour oral glucose tolerance test values are 140 to 199. It's diagnosed when fasting blood glucose levels are 100 to 125. They usually don't have symptoms. However, they can long-term damage to the body, especially the heart and blood vessels, may already be occurring. It's important for them to undergo screening and understand risk factors for diabetes. They can take action to prevent or delay the development of type 2 diabetes. So you want to encourage them to have their blood glucose and A1C checked regularly and monitor for symptoms of diabetes such as fatigue, frequent infection, or slow healing wounds. Maintaining a healthy weight, exercising regularly, and making healthy food choices have been found to reduce the risk of developing overt type 2 diabetes in people with prediabetes. So your A1C is basically the average of your blood glucose levels in the past 3 months, and you want that to be, I'd say, less than 6 or like 6.5. Okay, here, an A1C of, so diabetes is made when you have an A1C of 6.5 or higher, so you want 6.5 or lower, probably, yeah, 6.5 or lower. That's what you want to keep it under, because if they have higher than that, then they can be diagnosed with diabetes. With their diet, some ways that they can help with their diet would be like get rid of excessive carbs, limit the sugars. You don't want them to have a whole lot of like fats or red meats. Like keto diets, they're good for losing weights and stuff, but they're hard on the kidneys because they can have like a lot of red meat. They can have a lot of fats. With your cardiovascular system, having a lot of like that stuff might not be the healthiest. So you don't necessarily want to push them onto a keto diet. You just want to push them on a healthier diet, which is like adequate fruits and vegetables. You want to have enough protein, not excessive amounts of protein. Don't have like a whole lot of sugar or salt. Just like we've talked about we've learned about like heart healthy diets. It'll be kind of similar, I guess. So then we have gestational diabetes. That's a third type. So then we'll go on to type 2. So type 2 diabetes, most prevalent. Many factors contribute to the development of type 2 diabetes, including being overweight or obese, being older, having a family history of type 2 diabetes. It's caused by a combination of inadequate insulin secretion and insulin resistance. The body either does not produce enough insulin, or it does not use it effectively, or both. So with there's like with the structure of insulin and glucose and stuff, they'll have these like little like grooves that they fit into. And with insulin resistance, it's kind of like our instructor used the example of like a key and lock. Well, with insulin resistance, you could just imagine that someone like took the key and they shredded like some of those like the knobs off. So then they put the key and you try to turn it, and it doesn't work quite well. So with some of the oral anti-diabetic agents, you can just kind of like imagine them as like they like slip onto the key, and then they like they have the groove stick out a little bit more so you can actually turn the lock again. That's kind of how I would think of it. Okay. So individuals that have a relative with type 2, they're going to be more likely to have it. Insulin resistance, that happens when the body tissues don't respond to the action of insulin because insulin receptors are unresponsive or insignificant in number, or both. That's on muscle, fat, liver cells. When the insulin is not properly used, the entry of glucose into the cell is impeded, resulting in hyperglycemia. So there's other symptoms here too. Individuals with metabolic syndrome are at an increased risk for developing type 2 diabetes. It has 5 components: elevated blood glucose levels, abdominal obesity, elevated blood pressure, high levels of triglycerides, decreased levels of high-density lipoproteins. Those are the good ones. You want to have those. So these guys can reduce their, like the people that have metabolic syndrome, they can reduce their chance of developing type 2 by having weight loss and regular physical activity. So that's something that you might be able to teach on. And then there's also a condition of diabetes. It's called secondary diabetes, and yeah. So let's just go over type 2 a little bit further. So they can have metabolic syndrome. The pancreas continues to produce insulin, but it's insignificant, or they can have insulin resistance, or both. But one of the complications that they can present with is called hyperosmolar coma, and that's not an acidic state like diabetic ketoacidosis. So, and also these people with type 2 diabetes, they may not feel like they have the symptoms or signs, or the signs or symptoms of being diabetic. They might be like, just going for like hypertension, and they do some lab results, and then they find out, oh, your A1C is high, and then that's how they get it. They might not have the symptoms of being a diabetic. Secondary diabetes, this happens when they have another medical condition that causes their blood glucose to be high. And with this condition, we don't necessarily want to educate them or say, hey, you got diabetes, because it freaks them out unnecessarily, and as soon as the treatment or condition goes away, then their diabetes should go away. Type 2 and type 1 diabetes, they typically don't go away, especially type 1. So this is not like a true diabetes. And in clinical, sometimes we can see people on like insulin, and they don't have a diagnosis of diabetes, and that's because they're hospitalized and they have more stress, and they might have them on corticosteroids, which increase their blood glucose. So it's not something that we're too terribly concerned about. What we would want to do as nurses is monitor their blood glucose, especially if they're on total parental nutrition. You can get this condition when you have Cushing's syndrome, which is just see. I think I did one on. So that's when you have an increase of the secretion of the corticosteroids. You can have it with hypothyroidism because their metabolism is a lot higher. You can have it with pancreatitis. You can have it with parental nutrition. You can have it with cystic fibrosis, medication effects like corticosteroids. You can have it. So we don't really educate about it or tell the patients about it because it can go away. We don't want to stress them out even more. So just monitoring is basically all we're going to do. So diabetes is diagnosed with a fasting plasma glucose of greater than 126. We're going to repeat it on another day, just to make sure we have we take the 2 readings and see. Random or casual plasma glucose, so if they just come in there and they have signs of hyperglycemia, we take a blood glucose and it's greater than 200 milligrams per deciliter, and they're having the symptoms, then they can be diagnosed with diabetes. 2-hour oral glucose tolerance test that's greater than 200 milligrams per deciliter, and that's with a glucose load of 75 grams. A hemoglobin A1C test of greater than 6.5. So those are all the ways that we can diagnose. The provider will diagnose diabetes, so I would be familiar with all those different lab values. If it's very high with symptoms, they're not going to be just sent home. They're going to be treated with insulin or something. Or you're not just going to be like, oh, okay, we don't really, like have your test back yet, so we'll just send you home. They'll probably do something. So just be aware what you would do for like an immediate like hypoglycemia or hyperglycemia client, that because these are some things that the provider might prescribe. Let's see here. Yeah. Okay, so insulin. We already kind of talked about the insulin. So yeah, some like you. The long-acting insulin is probably going to be given at bedtime. You're going to give it alone. You're not going to give it with any other kind of insulin. If you have high blood glucose, you have cell tissue damage. So even if it's in the person's record or chart or whatever that they've always been running a little bit high, you wouldn't want to just leave it with that. You'd probably want to do some kind of nursing intervention. So if there's like an exam and we have a person that's like 130 or something, and there's like a history of them always like running high, like the night shift says that they've consistently been at like 129, 126, 130 or something, we might, we probably might want to do like some kind of intervention, because if it's always, or like even like 200, because if it's always a little bit high and it's not like within the normal, as close to the normal range as possible, then the glucose is going to be damaging their cells. It can cause like retinopathy, it can cause peripheral neuropathy, it can damage the inside of their blood vessels, it can damage their heart. So we want to keep it as close to the normal range as possible to prevent future complications. Let's see. So if you have someone that comes in and they have like diabetes and we like treat them initially, we'll probably do like some of the teaching, but we're always gonna want to work with or refer them to a diabetes educator as soon as we can. You're gonna mark the vials when you open them. And once they're open, they're only good for about 30 days. You don't want them to be in extreme temperatures, so you don't want them like excessively hot or excessively cold. Some people put them in the fridge, some people leave them on the countertop. I think what I got from it is that you want to, like if it's opened, then you put it in a fridge. And if they're not used, then they can just be on a countertop, something like that. Or at least that's what I got from ATI. So with insulin pumps, they're most likely gonna have rapid insulin in them. Type 1 diabetes are probably going to use them more than type 2, because type 1, they are dependent on injected insulin. Type 2s, they might not be at that point quite yet. You're going to change patches in the like the catheter, then like the needle, every 3 days. You're going to want to make sure that they clean and like know how to change it so they don't get infections or anything. Rotate sites. There's a table 48-2 interprofessional care. That's on page 1125. I would pay attention to that. And then they have types of insulin box beside that. I don't know if I would pay too much attention to it. Let's see here. So we kind of talked about the insulin, so I'm not too worried. There's a pretty cool chart that's figure 48-4. That's on page 1129, no, 26. That's like a pretty cool visual. So let's see. So with the patient teaching and assessments, we should never assume that they know how to do anything like that. Just ask them what they know, ask them if they've done something before, ask them what their normal meal is, so that you get more assessment data. Like, you never want to have like nursing interventions before you assess, because you don't know, there's like so many things you could do. you want to have like some kind of guide first. So always like assess, and like one of the ways you could assess like what they know and like what you need to teach on is by asking them what they know already. So like always assess if they know how to do anything. The patient and caregiver teaching boxes, if you like see them, I would definitely pay attention to those. Exercise, here we go. Patient and caregiver teaching, that is on page 1128. I would go through that and definitely look at that. Assessing the patient treated with glucose lowering agents, I would pay attention to that one too. That is on a box that's on page 1129. There is a box, well, there's a medication box on page 1131 that would probably be good to watch. There is there's a drug alert for metformin, that's on page 1130. I would pay attention to that as well. There is a table, box 48-8, nutritional therapy, that's on page 1133. I would probably pay attention to that. I would also like go through the side and just like read through where they have the carbohydrates, fats, protein, alcohol, because you're going to be giving education about nutrition, so you want to make sure that you know enough about it. So if there's any questions, then you know kind of like where you're going. There's table 48-10, that's on page 1134. That's exercise for patients with diabetes. So education and exercise, it's going to be important, so I would go through that. And then there's self-monitoring of blood glucose on page 1136. I would also go through that. The highest ethnicity group for diabetes is Native Americans and Alaska Natives. And they're also more likely to get amputations. So like Native Americans, they have a higher risk for that. And instead of like just like them believing like, oh, this is what grandfather did, like had to go through, and this is what father had to go through, and we've had amputations, we've had complications and wounds, like gigantic wounds that won't heal, and death and stuff. Like instead of them just feeling like they have to go through that same cycle, you have an opportunity with these people in these communities to educate them and in a respectful, nice way, and like just like inform them that like it doesn't have to be this way. There's treatments that they can do, and there's like lifestyle changes that they can do to improve their outcomes and have a better life. So because culture can have a strong influence on the dietary preference and meal preparation practices, culturally competent care is important when you're trying to do like teaching or education. So like maybe there's like a special like ceremonial dish or something that they would like to have. Well, you probably don't want to say like you can absolutely not have that. You might be able to like substitute certain like carbohydrates in place of other ones, things like that. And also like just help them prepare like to like have a like if there's like special like meals that they want to have, then prepare them throughout the day so that they can actually have those and they're not as like bad. Like so like if they have like something that's a little more sugary, then maybe like have more like protein complex carbs, so it's not such a sugar spike and it doesn't like have like such like a peak and then a drop. So maybe like try to stabilize it, and then throughout the day don't have as many high calorie meals. That might be an idea. And then there's a health screening, that's table 48-13, that's on page 1138. I would pay attention to that as well. And then there's a patient and caregiver teaching, that there's a box for 1141. I would pay attention to that too. And the patient teaching using smartphone apps, because she mentioned it in class. Medic alert bracelets, those are important because if someone like passes out or like has a seizure or goes into a coma and they haven't been able to tell like the EMT people or the people around them like what condition that they have, having a bracelet is going to already speed up their treatment because instead of playing detective, they know what condition the client is most likely suffering from. So that would be something that you'd want to like teach them about. Patient caregiver teaching instructions for patients with diabetes. That's on 1142. I would pay attention to that as well. You're going to want to make sure that people that have diabetes, they always carry a small like carbohydrate snack around with them so that if they have like hypoglycemia, they have something and they don't like pass out or anything. And then anytime that they're going to be exercising, you want to have them have a snack before that. You want to make sure that they're well hydrated. If they're sick or anything or have increased stress, they might need a little bit extra insulin. And that's because the stress, like they have the corticosteroids, and that's going to increase their blood glucose. So they might need a little bit more insulin just to help their body deal with the stress. If they are like vomiting or if they haven't eaten or if they've skipped a meal, then you're not going to want them to take their oral anti-diabetic medications. If they've skipped a meal, then they don't have to take the rapid-acting insulin or the oral anti-diabetic medications because they don't have those carbohydrates, so they're not going to be getting that glucose. So if you give them the insulin or the oral meds, then it's going to cause hypoglycemia. So that's something to keep an eye on. So hyperosmolar hyperglycemic syndrome is a life-threatening syndrome. This happens with people with type 2 who are able to produce enough insulin to prevent DKA, but are not enough to prevent severe hyperglycemia, osmotic diuresis, and extracellular fluid depletion. It's less common than DKA. It often occurs in patients over 60 years of age with type 2 diabetes. Common causes are urinary tract infections, pneumonia, sepsis, any acute illness, and newly diagnosed type 2 diabetes. So things that increase their stress, like medical conditions and things. They often relate impaired thirst sensation and or functional inability to replace fluids. Usually a history of inadequate fluid intake, increased mental depression, and polyuria. The main difference between this and DKA is that the patient with this disorder usually has enough circulating insulin so that ketoacidosis does not occur. It also produces fewer symptoms in the earlier stages. Blood glucose levels can climb quite high before the problem is recognized. The higher the blood glucose level, increased serum osmolarity and produce more severe neurological manifestations, such as somnolence, coma, seizures, hemopharesis, and aphasia. These symptoms resemble a stroke, and immediate discrimination of the blood glucose is critical for diagnosis and treatment. So if they don't have the blood glucose level tested, then they're going to probably think it's a stroke, so they have to have it tested. So there's like a question that they're having these symptoms, and one thing that you might want to have checked is the blood glucose level. If they have a blood glucose level greater than 600 milligrams per deciliter, and a marked increase in serum osmolarity. Ketone bodies are absent or minimal in both urine and blood. So how you're going to treat this is going to be immediate IV administration of insulin in either normal saline or 0.45 normal saline. They usually require large volumes of fluid replacement since it's dehydration. Let's see. You want to do it slowly. They can have cardiac or renal problems and require hemodynamic monitoring to avoid fluid overload. When the blood glucose level falls to 250, IV fluids containing dextrose are administered to prevent hypoglycemia. That's because it's so high If you decrease it too fast, then the body can have hypoglycemia, even if it's like elevated. It can experience it like that just because the blood glucose levels were so high to begin with. So electrolytes are monitored and replaced as needed. Hypokalemia is not as significant in this condition as it is in diabetic ketoacidosis. Assess vital signs, intake output, skin sugar, laboratory values, cardiac monitoring, serum osmolarity, frequent assessing cardiac, renal, and mental status. So some of the complications of diabetes mellitus, that is a box on page 1148. That's some stuff that I'm going to plan to go over, because these are conditions that I should be aware of, so that the patient I'm educating, I can let them know that these are some of the complications if diabetes isn't properly controlled. It's not like threatening them by telling them this information. It's just advocating for their health and just saying these are some things you could expect or you could deal with if it's not being treated. So it's being honest, and it's also giving a motivation. There's a box on foot care that is on page 1151. I would pay attention to that. And then there's another box on page 1152. So I'm not saying a lot of the information in these boxes because there's a lot of boxes to go through, and it should be stuff that's easy to read through. But all the patient caregiver teaching, I would definitely look at all of those, because there's probably going to be pulling quite a few test questions from there, I'm thinking. Let me look at my notes, see if I've missed anything. So there's two problems with insulin therapy. That's the Stomoji effect, rebound effect, in which too much insulin causes hypoglycemia during sleep. You're going to check the blood glucose between 2 and 4 in the morning. Treatment is less insulin. Then you have the dawn phenomenon. That's characterized by hyperglycemia present on awakening in the morning due to release of counter-regulatory hormones in pre-dawn hours. So cortisol is released, corticosteroid, your hormones, or those are released, and then increases your blood glucose. Growth hormone, cortisol, possible factors, adjust timing of insulin or increase amount. Yeah, let me see if I can find it here. Okay, so here we go. So a high dose produces a decline in blood glucose. This is the strojomy. So the counter-regulatory hormones, so you have glucagon, epinephrine, growth hormone, cortisol are released and stimulate lipolysis, gluconeogenesis, and glycogenolysis, which in turn produce rebound hyperglycemia. So it's because they are hypo, and then their body tries to kick in, and then they become hyperglycemic in the morning. The danger of this effect is that when blood glucose levels are measured in the morning, hyperglycemia is apparent in the patient, or healthcare provider may increase the insulin dose. But it's caused because they already have hypoglycemia. So if the patient is experiencing hyperglycemia, checking the blood glucose levels between 2 and 4 in the morning for hypoglycemia will help determine if the cause is the Stojomy effect. The patient may report headaches on awakening and recall having night sweats or nightmares. At bedtime, a snack or reduction in the dose of insulin or both can help prevent this. Then the other one is the dawn phenomenon. And this happens when you have hyperglycemia also on awakening. Two counter-regulatory hormones, growth hormone and cortisol, are excreted in increased amounts in the early morning hours, and that might be the cause of this phenomenon. Most severe when the growth hormone is at its peak in adolescence and in young adulthood. Careful assessment is required to document the Sturgeon effect or the dawn phenomenon because the treatment for each differs. The treatment for the Sturgeon effect is less insulin in the evening. The treatment for the dawn phenomenon is an increase in insulin or an adjustment in the administration time. Your assessment must include insulin dose, injection sites, and variability in the time of meals or insulin administration. Ask the patient to measure and document bedtime, nighttime, and morning fasting blood glucose levels on several occasions. If pre-dawn levels are less than 60 milligrams per deciliter and signs and symptoms of hypoglycemia are present, the insulin dosage should be reduced. If it's high, then the insulin dosage should be increased. You also want to let them know about appropriate bedtime snacks. And then with insulin therapy, you can also have allergic reactions, although that's not too common, I believe. You can have the lipodystrophy. That's why you would want to have rotating sites. So I would just go and look through a lot of the boxes. Nutrition therapy on type 2 diabetes emphasizes achieving glucose, lipid, and BP goals. So you want to plan appropriate serving sizes, a reduction in saturated and trans fats. Low carbohydrates can decrease calorie consumption. Spacing meals is another strategy that spreads the nutrient intake throughout the day. A weight loss of 5 to 7% of body weight often improves blood glucose levels, even if the desired body weight is not achieved. Weight loss is best attempted by moderate decrease in calories and an increase in calorie expenditure. So like exercising, you're going to want to monitor blood glucose levels, A1Cs, lipids, and BP to see how effective it is. So you can do carbohydrate counting. The glucose-lowering effects of exercise can last up to 48 hours after the activity, so it's possible for hypoglycemia to occur long after activity. It's recommended that patients who use medications that can cause hypoglycemia schedule exercise about 1 hour after a meal, or that they have a 10 to 15 gram carbohydrate snack and check their blood glucose levels before exercising. They can eat small carbohydrate snacks every 30 minutes during exercise to prevent hypoglycemia. And then if they do too much of a strenuous exercise, then it can cause the stress hormones and all the other hormones to get released, and then they have a temporary elevation of blood glucose. So, yeah. I think just paying attention to a lot of the boxes is the way to go for this. That's what I'm going to do. The nutrient teaching, exercise teaching, diet teaching. You want to teach them about their medications. You want to teach them about their care, like how to care for wounds and things like that. That's what I would pay attention to. You don't want to exercise if your blood glucose level is less than 100. Pancreas transplantation, that can be used for patients with type 1 diabetes who have end-stage renal disease, had or plan to have a kidney transplant, eliminates the need for injectable insulin, lifelong immunosuppression therapy, though. And in lecture, she said that people that had pancreatic transplantations, their diabetes actually went away. So. You can have an environmental versus genetic link of developing diabetes. Increased stress increases the cortisol, which increases blood glucose levels. Processed foods are mostly what people in poorer or more stressed communities have, in that it's not proper nutrition. Usually they're packed full of salts and sugars, so that can cause an increase in your blood glucose levels. And it's not easy to get like wholesome good foods because they're expensive. So you're going to want to do education, but it might not be well enough just to do education. They might know the good foods are important for them, but they might not be able to afford it. So working with like case management, maybe like social services, if you find out that they have poor nutrition, they can't afford it. Phone app, telemed, you can do that. Stress of illness and surgery, you want regular meals, increase fluids, continue oral agents and insulin, check blood glucose more frequently, notify the medical doctor if the blood glucose is greater than 240 or ketones are present in the urine. So with diabetic ketoacidosis, you're going to want to treat the dehydration slowly and decrease the blood glucose via an insulin drip. We already kind of talked about that. So they have abdominal pain, nausea, vomiting, dehydration, fruity breath. You got to treat it because it can get worse, so you can go into a coma and those sorts of things. So the laboratory findings with ketoacidosis, you're going to find that their blood glucose is greater than 250 milligrams per deciliter. Their arterial blood pH is below 7.30. The bicarb level is going to be less than 16. They're going to have ketones in their blood and urine. So you're going to assess them, then you're going to make sure that they you do like the ABCs. Correct the fluid and electrolyte imbalance, IV infusion of 0.9 normal saline, sodium replacement. You're going to want to put them on an EKG. The potassium is decreased by insulin, so that's why you would want to do the potassium replacement if the lab values show that it's too low. Insulin therapy after fluid resuscitation has begun, and you're going to give the insulin IV. We give glucose and insulin for conditions like hyperkalemia. So if you have a condition where you have to give insulin and they have a lot of blood glucose, then that's you can expect a low blood potassium. So you're going to have regular insulin in the insulin drip. Prime tubing with 20 mils of insulin mixed with normal saline. Because if you prime it with like fluids, the insulin drip, it's just like slowly. So if you don't like have it already in there, then it's going to take a long time for that to actually get to their system. So that's why we would prime it with the insulin. The blood glucose test every hour and titrate drip accordingly. Don't drop the blood glucose too fast to prevent cerebral edema. Neuro checks, cardiac monitor possibly. And then we talked about the other one. So hypoglycemia, blood glucose is less than 70. You can have loss of consciousness, seizures, coma, and death. They might not be aware of their symptoms. 15 grams of simple carbohydrates, and then you're going to recheck the blood glucose 15 minutes later. You can give them orange juice, you can give them like candy, or you can give them those glucose tablets. If confused, be careful giving oral. You might not even want to give oral. You can give like an IM injection, or you can give IV 50 mils, I think it is, of of a glucose, and you can push it. Give protein snack afterwards to stabilize the blood glucose levels. Okay, here we go. Administer 1 milligram glucagon IM or subcutaneously. You can give 20 to 15 mils of 50% dextrose and IV push. Diabetic retinopathy is most common cause of new blindness in people ages 20 to 74 years. You can have the microaneurysms. You can have renal capillaries become occluded. You can have retinal detachment. You need to have annual dilated eye exams to see how to just like monitor your eyes and things. Diabetic neuropathy, nephropathy. So this is affecting your kidney. So you have damage to the blood vessels that supply the glomeruli. Leading cause of end-stage renal disease. Prevention is blood glucose control and the use of ACE inhibitors. You're going to want yearly screening, urine albumin, serum, creatinine, just to monitor like how the kidneys are functioning and how they're doing their job. Diabetic neuropathy, you can have damage due to metabolites and impaired blood flow. You can have loss of sensation. You can have pain. You can have paracentesis. So you can have gabapentin and pregabalin. Those can be some medications. And then you have the duloxetine for that. Autonomic, you can have the gastroparesis, postural hypotension, erectile dysfunction, and neurogenic bladder. So that's where it's like not emptying all the right way. You can have severe foot injuries because you lose sensation and you can't feel pain with the conditions worsening. So my grandfather had big, lousy, horrible ulcers on his feet because he couldn't feel anything and he would bump into the furniture all the time. And he was doing the dialysis through his abdomen and that wasn't working, so then he had to get a fistula, and then he gets dialysis through hemodialysis now, and that's working better for him. But it wasn't working. He wasn't taking the fluid off like it should have. He was falling nearly all the time. He had a lot of the toxins building up, and he wasn't himself, and it was really hard to talk to him, and he just seemed like out of it, like he had dementia or something. It was pretty horrible. So yeah, making sure like he also had diabetes too, so, and yeah, blood pressure meds. So there's a lot of conditions that can kind of, I guess, go into this. And yeah, with his feet, he lost sensation and he would get big injuries. So like if you're like a nurse, you should always like assess these injuries because they can get really bad and they might not care for them, and they might have impairments where they're not able to like bend over and like look at their feet. Someone that's like helping care for them might also be older too, or might not be able to care for them as well. So definitely important to assess. So infection, you have delayed immune response, impairment, phagocytosis by neutrophils and monocytes, loss of sensation may delay detection, harder to treat when get sick, injured, easier to get infection and injury. With older population, the prevalence increases with age. Hypoglycemia, unawareness is more common. Delayed psychomotor function could interfere with treatment. Education based on individuals' needs, using a slower pace. Some things that are good is if they have problems with injecting insulin, you can use insulin pens have like larger knobs or something, so they can inject easier. So I think that's all I'm going to do for now. That's the question I believe that has the most. That's chapter I believe that has the most questions. I have some charts for that I've been making for the hormone chapter. I'll just try to show you these, and then you can kind of like look at them. I'll try to make another video, but I haven't been able to study like I wanted to just because my headaches, unfortunately, pretty bad. So So, and then here's something I get these free things from the nurse. They give like Friday freebies, and then I can look at them. So there's like some things on there that might help. And then I guess I'll see about making. I might be able to make the video tonight, and then I'll just upload it later. Anyway, I hope it helps. If you guys have any like tips or tricks or anything you want to share, you can put it in the comments or anything like that. So anyway, I hope it helps. See ya.